And let's start with these two cases. The first of them is for a female patient, 84 years old, diabetic, who is giving a history of being of outdoor activity. The second patient is also a female patient, 72 years old, who is suffering from rheumatoid arthritis, chronic kidney disease, and giving a history of indoor activities. So what is the best way for their management? For this question, we will try to define the criteria for decision making for management of distal femoral fractures in the elderly, and we will show how we can choose between fixation versus replacement for managing such fractures. But most importantly, I hope at the end of this presentation that we can change our attitude towards the elderly distal femoral fractures. About 50% of these fractures are actually occurring in patients above 70 years old. And these patients are characterized by being physically dependent, having multiple comorbidities, and depending on multiple drugs. And their bone is actually pathological because of osteoporosis, and also their joints are arthritic. And for distal femoral fractures in the elderly, it's characterized by being, as regard the articular segment, having a very short segment which might be comminuted, and for the metaphysio-diaphyseal segment, it's also comminuted and might be occupied due to the presence of previous implants. So we can see that we are dealing with different patients that is having difficult fractures occurring in pathological bone. The mortality risk following such fractures might be exceeding what we know with the hip fractures. And actually, if they are treated with non-surgical treatment management, it might reach up to 38%. But fortunately, with surgery, this risk might be reduced to 13.4%. And it could be predicted according to the previous ambulation level of the patient, the presence of comorbidities, and the most important is it is related to the time to surgery. So our first goal is to do no further harm for such patients. After surgery, most of these patients try to get in bed, and this is known as the bed rest syndrome. And actually, this syndrome is bad because it leads to multi-system irreversible consequences. So our second goal is to return to the previous level of activity as early as possible. So we will find that there is recommendations as regard the non-operative treatment to be only for the non-ambulatory patients and those who are having a high anesthetic risk. But you should remember that at least one post-operative complication might occur in up to 37.5% of the patients. So you must weigh the benefits versus complications. And if we looked at these pathological bone and arthritic joints, you should expect that fixation might lead to bad complications, like being on wheelchair in up to 23% of the patients, non-union in up to 24% of the patients, and again, the risk of mortality in up to 25% of the patients. So when you are trying to treat your patients, you should think about a single shot surgery. So in such difficult fractures, we will have another option, which is the replacement. But if we review the literature, we will find that there is no strong conclusion as regards which is the best. Although that distal femoral replacement is an optimistic option because it will eliminate the risk of non-union, malunion, post-traumatic arthritis, and the most important, the post-traumatic stiffness and implant failure. It's also having complications like that. We are dealing with these fractures by extensive exposures that might lead to infection, and also because we have limited salvage options in case of failure. So what are the criteria for choosing the distal femoral replacement? It's better to be done in patients with advanced age, patients with poor bone stock like rheumatoid arthritis patients, patients with advanced osteoarthritis, and in comminuted fractures. And it's better not to be done in young active patients, and also it's difficult to be done in patients with ipsilateral long stem hip implants, and of course it's better not to be done in cases of simple fractures that have enough articular segment to be fixed. Active infection, and here I'm not talking about open fractures, are a contraindication for surgery, and also we cannot do joint replacement in cases of disturbed extensor mechanism. These will be the criteria for choosing fixation for such fractures. To have a young active patient when there is an ipsilateral long stem hip implant in the metaphyseal diaphyseal segment, and in cases of simple fractures with enough articular segment. It's preferred to do double plating for such fractures because it will allow early weight bearing, but you should remember that it might lead to construct stiffness that might lead to complications like non-union. So if we return to our patients, first patient, we'll find that it is having an outdoor activity, having a simple fracture that's not comminuted at the level of the articular segment, so there is enough segment to be fixed, and this is what have been done for the patient, the double plating technique, and from the day one, it could weight bear, and on follow-up, we can see that the patient is walking freely. Second case, it is having a pathological bone, arthritic joint due to rheumatoid arthritis, and giving a history of indoor activity. So distal femoral replacement was chosen for her. So in conclusion, we must remember that we are dealing with different patient criteria that might have a difficult fracture, and we are working on pathological bone and arthritic joints. Our goals will be to do no further harm for these patients, to return to the level of activity as early as possible, and when choosing surgery, it should be a single-shot surgery. Comparing fixation versus replacement, there is no strong conclusion in the literature, but we can choose our patients according to the following criteria. Replacement is better to be done in patients with advanced age, in cases of poor bone stock, like patients with rheumatoid arthritis, and in cases of advanced joint arthritis, and it's better to be done in comminuted fractures. For the fixation, it's better to be done to young, active, elderly patients in cases of the presence of contraindication for replacement, like ipsilateral long stem hip implants, and of course, it's better to be done in cases of simple fractures with enough articular segments. Thank you.